Okay, good afternoon, everyone. Can you hear me?
We can hear you, lady.
Yes.
That's what I'm saying. I don't think they can hear me.
Just turn this all the way up. And now,
I think so.
yeah, you can do the.
Okay. Good afternoon, everyone. I'm Lady Dancer, one of the PGY2s, and I'll be the one to give the afternoon report today. So I have a 57-year-old female who presented to the clinic with worsening headache and macrocephaly. So 57-year-old female with no known past medical history presented to the endo clinic for follow-up. She was initially seen in 2018 when she presented with like intractable headache 3 years prior to presentation, and was told by her sister that her head is becoming bigger. So patient has no past medical history. She only told me that she has like a bone disease, which is non-specific. She doesn't know what kind of bone disease or what type of bone disease. She has no surgeries in the past, no known family history. She's a non-smoker, do not drink alcohol or use illicit drugs, and has no known allergies. Patient is not on any medications as well. So I would like to ask, what else will you ask in your history?
Mantesh is asking, are her hands getting bigger?
I'm not hearing anything.
I feel like someone's speaking, but I don't know if,
Okay,
did someone, all right, here we go. So Mantesh, are her hands getting bigger? And Tomo, are there any visual disturbances?
Patient's hands are not getting bigger, but yes, she has visual disturbances.
Gait changes?
No gait changes.
Do you have any history of like recurrent fractures?
No.
So what was the deal with the headache in 2018? What was the diagnosis? What did they do about it?
So she just told me that at that time she was at Dominican Republic when she went to the doctor. At that time, she was having like severe headache almost daily. And her sister and the auntie told her that her head is becoming bigger, and some blood work was done. And she was told that, and some imaging at Dominican Republic, and she was told that she has like a bone disease. That's all what I was able to get from her.
All right, we have more questions. Is there any urinary incontinence, auditory disturbances? Do you see any central obesity?
Yes, she's overweight, she's obese. She has like hearing disturbances. She has hearing loss, and but no urinary symptoms.
Okay, I'm gonna take a second here and we're gonna go back to Mantesh, who's also asking about bone pains. Hold that thought. So Joe, why would you like to know about auditory disturbances, and what do you mean by that?
Ongoing with the visual and the auditory and the macrocephaly, thinking something obstructing on something impinging
Gotcha.
Auditory system.
Gotcha. All right. So hearing loss. All right. And then why urinary incontinence, Andrew? What are you thinking about?
Thinking about people were asking about gait problems. So I was just thinking about the triad associated with NPH, hydrocephalus.
All right. Anything else in her history that would point towards hydrocephalus or normal posture hydrocephalus? You want to go back in the history and show us? Go back in one slide, lady.
Okay.
All right. Or yes, exactly. It's the HBI perhaps.
No, not really. I mean, the main complaint was that somebody else noticed that her head was getting bigger, but you wouldn't see that with hydrocephalus.
Okay, so I'm gonna use that in Tomo. Why central obesity? What are you thinking about?
First of all, she came to the endocrinology clinic, so my differentials are, broad, but my main focus was endocrinology disease such as Cushing syndrome. Patient with Cushing syndrome or Cushing disease can have central obesity and increase in size in the face. So that's why, I asked the
Right.
question.
Yeah, all of these things absolutely make sense. Perhaps you're thinking, well, maybe this is the way they're describing it. Whereas we don't know, right? It's a report. We still haven't seen a physical exam. Okay.
That's,
Manjeet,
I have
yeah,
a question.
Yeah.
Any specifics on like the comments of the head getting bigger in size? Did they, was it like a specific part of the head, like the forehead? Or like, is she having like things like hats that she used to wear, did they no longer fit? Any mention of that?
Central Boston.
So the patient showed me her previous pictures, like how she looked like when the head wasn't bigger and how she looks now. So she's kind of having more of like frontal, like the forehead, it's bigger compared to the other side of the head. Yeah, it's more frontal.
It's a very good question, yeah.
So more like the face or the frontal part of the skull, like the top of her, I don't know, forehead.
Yes, so it's more on the frontal, like the frontal side of the forehead.
Okay.
Let's say, yeah, the frontal bone area. So that's what's bigger, not the face. The face is kind of smaller compared to the head. So
All right, and we'll get to the physical exam, but I see here, so Mantesh, you're asking about bone pains. What is your differential here?
I was thinking maybe about whether history of bone disease, is it Paget's disease of the bone with pains. I know that can cause pain in the head if you get a lot of like bone like turnover in the skull, hearing loss, because you can get maybe expansion of the bone, it crushes the nerves. So maybe Paget's disease, but also I don't know. Yeah, just a random thought.
Okay, I see a few faces smiling, heads bobbing, yes. All right, and then of course, many more other questions. What Cara's asking, did she mention that she had any coarsening facial features? Someone noticed any bowing of the legs? And I guess that's something we'll see in the physical exam as well. Did she mention any of this, lady? Like facial features were changing or coarsening? And then Wakar will tell us what he's thinking about with this.
So patient's facial features were changing, like let me take that back a little bit, because he told me that her ears were kind of more getting outwards, like her ears are kind of I don't know how to describe that, but her ears were getting like more out to you, just like more, yes.
But no coarsening of the facial features. So what were you thinking about, Wakar? What made you ask that question?
Well, the major differentials are here, as everyone mentioned, the Paget's disease and acromegaly. So in Paget's, you can have coarsening facial features. Also in the acromegaly, in the Paget's disease, because of the bone turnover, you do have the bowing of legs.
Okay. And to Matej's point, frontal bossing will be part of those features as well. And then Archana's asking excessive sweating, arthritis. Archana, where would this fall in your differential?
No, I guess like in gigantism, like too much of growth hormone, macrocephaly would have like other symptoms like oil glands secreting too much, like you're getting more sweaty, and then arthritis when your bones are also like trying to enlarge, you'll end up having like joint pains. So.
Lady, did she mention any of these symptoms?
Yeah, just like generalized body pain or bone pain, more on the shoulder. That's what she said she has.
More like one joint and not necessarily an excessive sweating or diaphoresis. Okay. And then Mantesh, you're asking. Sorry, go ahead.
No excessive sweating.
Gotcha.
And lady, when with the facial features, does she notice her tongue is getting bigger, or the jaws are getting, like the jaw is getting bigger?
No.
And then Mantesh, you want to know if she's a diabetic, or if we have any previous hemoglobin A1Cs or diagnostics. What are you thinking of again?
So
I'm thinking if the like acromegaly is associated with insulin resistance because of the way the thing works. So just maybe if there's a history of that.
We'll see if she has any acanthosis in her exam as well. Lady, what did she mention any prior medical history?
No. So it's only like this bone disease, that's all. So no diabetes, no other medical condition.
All right.
Who sent her to the endo clinic? Like, is this her first visit? And why? Why is she there?
So I just, as I said in the HBI, so she initially came to the endo clinic when she came from the Dominican Republic with those symptoms, and seeing the doctor that he has this bone disease. So he came back to the United States to see an endo doctor. So initially they saw her, but due to COVID, she lost the follow-up. And actually the day that I saw her in clinic, that's her second visit, when she like kind of lost follow-up, and not much has been done.
Okay. And I think Fatma, we already commented on changes in vision or hearing, but lady, if you want to repeat, did she have any changes in vision or in hearing?
Yes, so patient has like, she said that her vision is becoming worse for the past 4 months, and she's not hearing well either.
Okay. All right.
So can I go to the next slide? So on review of system, so patient has headache, poor vision, hearing loss, and generalized body pain. Otherwise, the rest of the review of system is negative. Vital signs is only kind of remarkable for like blood pressure, sometimes at the hypertensive range, like 142 systolic, and like she's obese, BMI of 39. The rest of the vitals here are unremarkable and normal. On physical examination, she has this like enlarged frontal bone with visible blood vessels on both sides, more on the left side of the temporal area. She also has like mild tenderness on palpation of the bilateral shoulder joint. The rest of the physical examination is unremarkable. So I just want to have like what will be the summary statement for this patient.
Of the many people who asked questions before, does anyone want to take a stab at this? Vincent, you're smiling at the camera.
Okay, yeah, I can give it a shot. So let's see, we have a middle-aged woman who comes in with chronic headache associated with enlargement of the head from frontal bone, also associated with increased vision, decrease in vision and hearing, and generalized bone pain. Physical exam is significant for the frontal enlargement of the head and also mild tenderness in the shoulders. And yeah, that's pretty much where I am.
Yep. So yeah, so that's great. So middle-aged female with no known past medical history, just for like a bone disease unknown, presented to the endo clinic with intractable headache and microcephaly, hearing loss, poor vision, and generalized body pain. Vital signs remarkable for mildly elevated blood pressure, and physical examination is significant for enlarged frontal bone.
All right. So based on the differential that we came up with, what labs would you guys want to order? Oh, do we need any imaging tests at this point? She's walking into the endo clinic as a diagnosis of a bone disorder. What would you like to order for this person? So Lantage, glucose, ALP, and growth hormone. We see from Brohit, calcium, PTH, vitamin D. Okay. ESR and CRP from Andrew and Joanne. All right. ALP. All right. So those of you who suggested ESR, CRP, what are we looking for with inflammatory markers?
Giant cell arteritis.
What? Sorry, say that one more time.
Oh, giant cell arteritis,
Okay.
temporal arteritis. Yeah.
And what makes you think of giant cell arteritis in this patient?
I mean, there was mention of a prominent unilateral enlargement of the blood vessels in the left temporal region.
Okay, and the headache.
She's also had this vision loss, even though it wasn't specified whether it was like unilateral, but just based on those two findings or those two pieces of information, I would want to check inflammatory markers.
Okay.
Also, the shoulder pain could be
Shoulder pain,
the
yeah.
stiffness consistent with PMR.
Okay, so polymyalgia rheumatica could be associated and a never misdiagnosis. Okay. Anything else that you would ask in the case that you're suspecting GCA? Anything you would ask for?
Fever.
In terms of diagnostic workup?
Oh. Temporal artery biopsy.
Okay. All right, so let's hold the steroids on this patient for a second. Let's go back to calcium, PTH, and vitamin D. Rohit, what's making you think of calcium disorder or bone disorder?
So one of the differentials was Spaghett disease, and like the calcium phosphate and PTH help us to kind of distinguish between the different types of bone diseases.
Okay, so we're gonna hold that thought. And yeah, sometimes certain deficiencies and hyperpara, and maybe that's related to some of the bone pain that's happening. We'll talk more about calcium and Paget's. All right, ALP, Wakar, what makes you want ALP in this patient? And Fatma,
Well,
and
ALP, yeah, the ALP signifies the increased bone turnover in the Paget's disease. Calcium, phos, PTH will be normal, and the alkaline phosphatide would be elevated, signifies towards the Paget's.
Okay, any other labs that you would add to the ALP to suggest that it's coming from the bone or it's coming from any other organs? Okay.
GGT.
Wonderful. All right. What if the GGT is elevated? Where would it suggest that the elevated ALP is coming from? If this patient had an elevated ALP, biliary. Okay. Wonderful. All right. And then we're getting X-rays of shoulders and long bones and skull because we may see something there. And then I see suggestion of a very comprehensive endocrinologic workup because we may be suspecting there's a functional adenoma at some point with an MRI pituitary included. We'll talk more about that. All right. Lady, what tests do you get in the endo clinic for this patient?
Okay. So we got labs. We kind of send everything, CMP, calcium levels, which is the calcium of 9.3, which is like a high normal, alkaline phosphatase, blood, which is like 137, which is high. And we also got the bone specific alkaline phosphatase, which is also high, and vitamin D, which is at the lower end. Parathyroid hormone also is elevated. Yeah, those are the abnormal lab findings. So this is what we got with the imaging. So anyone wants to comment on that?
Well, the skull looks thick.
Lady June saying that the skull looks thick. What do you see? Oh, and Mott Eden from Unpage. And Archana is surprised at the imaging that you showed. She's saying, oh boy.
Is this image like compressed like vertically? I mean, or like, are these the actual proportions of her head and neck?
I agree. I have the same question. It looks a little alienoid.
Yes, it's a little bit stretched just to give the picture a more quality, but that doesn't change whatever we're saying. So whatever we're saying here is real. It's a little bit stretched, I agree.
So that's sort of a condyle appearance, lady. I mean, you can see there's some changes in the bone, whether it's like sclerosis or lytic lesions. It just doesn't look normal, right?
Sorry,
Yes.
one quick question. So this patient with headache and vision change, did we like treat her as outpatient for the rest of the duration, or did we consider sending her to ED for a quicker eval because her symptoms were like definitely neurological involvement too?
She never went to the ED. So from Dominican Republic, came to our endo clinic. He never passed through the ED. So he has never been treated for anything else. So I never saw a neurologist or any other specialty.
So sometimes that happens, that patients want a second opinion, and even if they had a diagnosis, maybe they weren't started on medications or they don't recall being started on medications. Maybe that was the case with your patient, lady, and she just came to make a diagnosis, a formal diagnosis, and maybe start treatment.
Yes. Yeah. So looking at this image, you can see that there is kind of thickening of the bone and with more of a sclerotic pattern, but we can see some areas of, so this is kind of like a very, very thick bone, like the bone cortex is very, very expanded and thickened. This is more all like kind of sclerotic, and you can see some areas, some small areas of lytic, but more of sclerotic bone than lytic areas. So this is like kind of the right side, the same image on the left side, and although also how to call it, the catwalk view, like from above. So I'm now looking at the labs and seeing those images. What are some of the differentials that we're thinking about?
So what's up? There you go. Fatma, Paget disease.
What was the albumin? It is a real hypercalcemia.
The calcium. What's the question?
You have albumin to correct the calcium and see if this was.
No, I did not see the albumin to correct the calcium, but I don't think patient has like low albumin. So that calcium is kind of accurate.
I'm just gonna say it was ionized calcium. That confirmed. We just didn't add it to the slides. And then the differential is expanding: myeloma, hyperparathyroid, primary hyperparathyroid or parathyroidism. Okay. Vincent, what makes you think of hyperpara?
Oh, just because the calcium was elevated and the PTH was also elevated, so that's consistent with primary hyperparathyroidism, just based on the lab results.
Okay, Fatma is supporting you. Does anyone remember the imaging that would be consistent with hyperparathyroidism or something like step 1 almost? No.
I think it can give you osteolytic lesions, but I'm not sure.
I think Max was unmuted. Yeah, that's something, right? That it had a name. All right. So while we think of that, cortical sclerosis is what Rohit is saying, and then Mantesh, vitamin D deficiency to cause the radiologic images. Mantesh?
I think it was bad enough. I don't think hers is bad enough, but I know it can really mess up bone because you get like the rickets and all that in kids. So like, you know, I don't think hers is bad enough, but yeah.
Okay. All right. I mean, maybe in extreme cases, I don't know if it's consistent, and Dr. Pergolino can help us here if he's ever seen, you know, a bad case of vitamin D deficiency leading to osteolytic lesions. But I don't know if Dr. Pergolino can hear me, but I think this is a pretty good differential. Oh, there we go.
Sorry, I got distracted. I got a call and I'm getting an email. Sorry about that.
That's okay. We were just discussing the differential for this case, so we'll bring you back at the end of it, so you can keep track of all. Okay. All right. All right, lady. So I think before you move on, is it my turn to share something? Lady?
Okay.
Would it be okay if I share something?
Yeah.
All right. So honestly, I am not the GI person in this group of chiefs. So I made my best to kind of go through what osteitis fibrosa kystic. Did you Google that, Joe? You do not remember this from STEP. Yes, there you go. That was the longest name ever. I was never going to remember that. Okay. So yeah, so mild hypercalcemia, some elevated LP, and to me as an intern, I know you guys are, you know, second and third years now, but it's always good to review. But for me, it was always challenging to know like what to do next, right? You have a patient that's coming with a potential diagnosis that's creating some bias in what you're seeing. Obviously, they're walking into the endocrinology clinic. They must have something endocrinologic going on. I love the differential that you guys created, and I think it's good to keep it broad because we never really know what's happening. You know, most of you kind of honed in into a possible diagnosis related to the bone. Now, when I do see an LLP that's elevated, I don't know about you guys, but I think of several organs, and do forgive me about my terrible handwriting. What organs do you remember, you know, being related, or organ systems related to an elevated alkaline phosphatase?
And you're trying to share the screen from.
Oh, it did not share?
Yeah.
Oh, sorry. Let me see. So no, it's my Zoom then. No? How about now? Yeah.
Maybe you need to stop sharing the first. No?
Usually it's someone I can take over, but I think it's probably my Zoom that's not working from here today. So that's okay. I mean,
View options on the top. You can, there's two shared screens. You can select Sananda Makuzuma, and then you can see Sanish.
Yeah, it's telling me that I'm sharing screen, so.
Maybe you can stop sharing.
That's what I want to do.
Stop sharing.
Yes, I will. Hold on. I'll stop sharing. Yeah.
Oh, yay. Smart. Okay. So that's my terrible handwriting. I should probably delete that. Well, anyway, so organs that are related to an elevated alkaline phosphatase. What's the first thing that comes to mind? Because I know it's what comes to my mind first. No? The GI people on the call? All right. It's okay, we're all tired. All right, so there you go, bile, liver, fantastic. Then we also know, as we were discussing just now, that it might be related to the bone and even the placenta. And I discovered some other organs are also associated with an elevated ALP. So,
White cells.
say that one more time.
White cells.
Yes. And then, well, I'm not gonna write the whole thing, but yes, prostate and then pancreas as well, and the kidney as well. So alkaline phosphatase is actually the standard liver test for reflecting cholestasis, right? So let me write this down. So when we do have an elevated alk phos, that's one of the first things I would want to think of. But we have to complement this with the gamma glutamyl transferase, or GGT, right? So be reminded this is not part of our typical hepatic function panel, so that's something that we need to get, and maybe that's why that, and in addition to the fact that you got a bone-specific alkaline phosphatase, that you guys don't see it in this patient's case. Now, if the patient does have an elevated LFP, it's usually the next step in evaluating whether this is hepatic in source to get a GGT. Now, because GGT is everywhere in our bile ductal cells, then its elevation is really not very specific, but in combination with an LP, it can probably tell you that it is coming from the liver rather than coming from any other extrahepatic sources, right? So, if I were to write this down, draw here. So if I have an elevated LLP, the next thing that I'm going to get is a GGT. Now, what happens if the GGT is normal? So in this case, we know that most likely this is not coming from the liver. And there are many diseases that will cause an isolated ALP, and we mentioned the many organs. Now, there could be non-pathologic elevations of ALP. So let's say if you have, someone that has a high bone turnover, like bone growth, children, adolescents may have an elevated ALP. I read somewhere that, people over the age of 60 may also have elevated ALP without it being pathologic. Late pregnancy, that could be something normal because there's an influx from the placenta, and then that could cause that. Now, in a patient that does have cholestasis, you would think that the alkaline phosphatase will likely be elevated at least 4 times the upper limit of normal. And I mentioned this because in other, diagnoses related to the liver, you may have a mild elevation of ALP. So like congestive hepatopathy, in viral hepatitis, I read somewhere also in infiltrative disease, ALP may be elevated. But usually if this is cholestasis, it will be very elevated. Now, the magnitude of the elevation will likely not tell you if this is extra or intrahepatic, right? So now, we should probably write, just to leave it here, we mentioned fractures and we mentioned bone disease, but also diseases related to the thyroid and the parathyroid, okay? Now, the first thing when we have an abnormal GGT would be to get an ultrasound of the right upper quadrant and to see the hepatic parenchyma and to see the bile ducts, right? Now, of course, this is not always, very, very helpful. It might not be telling you much because of how difficult it is to look at the bile ducts from an ultrasound, and maybe there's gas in the bowel and you can't get a pretty clear image. But in certain cases, we can tell if this is, cholestasis due to like intra or extrahepatic obstructions, right? So now, how can we know this? If we have dilation of the bile ducts, most likely this is something extrahepatic, right? When I think of extrahepatic causes of cholestasis, what do you guys think would be the most common cause of this? A stone, okay? So cholelithiasis. I love how Montesh is participating, thank you. Now, yes, it could be a stone, it could be a malignant obstruction coming from anywhere. So either the pancreas or the bile duct itself. And then chronic pancreatitis, when it causes strictures, it can also cause, extrahepatic cholestasis. Now, if we do see something that suggests an obstruction, and this is sort of something that happened acutely, then probably our next step, if possible, would be to get an ERCP, because you can get a diagnosis and potentially you can facilitate any drainage of the biliary ducts. Now, when this is more of a chronic issue, or you can't really tell if there's any obstruction, then perhaps even in patients that can't get an ERCP, then our next best step would be an MRCP, just to evaluate the bile duct. Now, many cases, we do not see a dilation. And then we think, well, maybe this could be intrahepatic. And to me, this was the challenging part, because there are many, many diseases that could cause an intrahepatic cholestasis. So in this case, and I was thanking to Angad for sharing fantastic guidelines with me. One of the things that we need to get in this case, anti-mitochondrial antibodies, right? Do you guys remember what disease is associated with these antibodies? All right, perfect. Yes, fantastic. Primary biliary cholangitis, wonderful. And then in some guidelines, it's suggested, I don't know what the yield of this is, but to get also ANA and anti-smooth muscle antibodies. And apparently it's a must if you're ruling out any intrahepatic disease. Like I said before, if those are present, then we should take a closer look. Obviously, other things, we already mentioned it, drugs, any sort of toxicity, pregnancy even, parental nutrition can cause this sort of picture where you can't find an obstruction outside of the liver. What else did I want to share with you guys? Now, in the case of this patient, we do have, the help of an endocrinologist. So they did get a bone-specific alkaline phosphatase, which, like I said before, sort of explains why we don't have this, wonderful diagnosis. But if you do see this in an outpatient clinic and you don't have many resources, then maybe that's the best next step. It's pretty clear, and it seems like, we'll see now. I'll return the control to you. We'll see now, how to reach a diagnosis. In this case, you all saw this is probably Paget's disease and why, and how to treat this patient. Lady, do you want to share your screen? Mm-hmm. Okay.
Okay, so those were very good differentials, and thank you, Sani, for those for that discussion. So my diagnosis is most of you guessed, and it's right, Paget's disease of the bone. And some of the differentials of Paget's disease is metastasis disease. So as you can see in that skull X-ray, you can see mixed sclerotic and lytic lesions. So sometimes you can find it very difficult to distinguish if this is malignancy or if it is Paget's disease of the bone. And sometimes you need to do further imaging or you need a biopsy to make that diagnosis. So osteomalacia also, just like Paget's disease, may present with bone pain and elevated serum alkaline phosphatase. But in osteomalacia, you can see like pseudo fractures, especially in long bones, that can differentiate it with Paget's disease. Osteosarcoma and giant cell tumors of the bone are also differentials, but Paget's disease can have malignant transformation and cause osteosarcoma. And sometimes to make this differential, you have to know that Paget's disease of the bone is usually when it transforms to osteosarcoma, soft tissues are also affected. So these are some of the differentials of Paget's disease. So just a brief overview of what Spaghett's disease of the bone is. So it's also called osteitis deformans. It's characterized by an accelerated bone rate, a bone rate like remodeling of the bone. Sometimes you can have it at single bone or sometimes at multiple areas. Most of the areas that are affected is the skull, the spine, the pelvis. The skull, as in this patient, is not as affected as the spine and the lower extremities. For the skull, it's sometimes like 42% of the cases, while the spine and the long bones, it's up to 70% of the cases. But in our patient, it's the skull which is affected in her. So affects like 2.3 to 9% of the population, usually after the age of 55. Men are typically affected. And it's very common in people of European descent, very common in England, Scotland, and Central Europe. And it is also found in the United States, Canada, and Australia, and very, very rare in Asians and Africans. So what causes Spaghett's disease? Genetics is one of the factors. Like there's a family history in 15 to 30% of the cases. So first degree relatives has up to like 7 times more likely to develop it than the general population. And most of these patients, like 50% with a family history and 10% who has like this sporadic form, they have a mutation in a gene that encodes, that regulates osteoclast functions, which is responsible for this bone turnover. So environmental factors are also said to be also implicated in the development of Spaghett's disease, but there is limited information about this data. But like findings have speculated that viral etiology is one of the causes. And there is very big evidence that measles virus as an etiological factor is very substantial, and measles vaccination is postulated to explain the declining incidence in Spaghett's disease. That being said, there are populations that where measles vaccination is not very much, is not widespread in certain communities. And Spaghett's disease has not been shown to be very, very prevalent in these populations. So usually the diagnosis is mainly imaging. So radiography are usually diagnostic, showing the characteristic deformity of the bone, usually thickening of the cortices. So earlier in the disease, it's very good to obtain kind of to see the lytic lesions, especially early on in the disease. So over time, you will see most of osteoblastic response and thickening of the bone compared to lytic lesions in the earlier part of the disease. Bone scintigraphy can also be used for diagnosis, which is like increased uptake in areas which are very, very affected with Spaghett's disease. CT scan, MRI can be useful. They are not very, very helpful in the diagnosis. The only time we use CT or MRI is when we want to kind of exclude malignancy, or if malignancy is a concern. So biochemical markers, just as I said, mainly radiographic, it's diagnostic, but we can we support it with biochemical markers. So an isolated elevation in alkaline phosphatase, it's very, very typical in these patients. And the rest of the biochemical markers are usually negative. So the Endocrine Society recommend that the initial biochemical evaluation of serum total alkaline phosphatase is very appropriate. And liver function, especially GGT test, can be used to rule out other potential causes of elevated alkaline phosphatase, just like Sunny was saying. So anytime you see an elevated alkaline phosphatase, the next step you do is to get a GGT just to make sure that the alkaline phosphatase is not from the bone or it's from other organs. And bone-specific alkaline phosphatase is also a confirmatory test, can use to confirm the diagnosis. So complications of Spaghett's disease is very many. It affects the musculoskeletal, neurology, the cardiovascular, and also has neoplastic transformation. So most of the kind of complications is the bone pain, deformity, and just as seen in our patients, he has the bone pain, neurology, the hearing loss, and the headache is very, very common. So cardiovascular, it can cause calcification of the aortic valve and some conduction abnormalities, and neoplastic transformation into sarcomas is is also one of the complications. So talking a little bit about the treatment, most of these patients are treated with bisphosphonates like alendronate and zoledronic acid. So the main indication for treatment in this patient is bone pain. So that is the main indication for treatment. But sometimes in areas which are very, very involved by the disease can be treated if like some areas are very, very affected. And before, prior to surgery, to decrease the vascularity in particular areas prior to surgery, we also use the treatment in those cases, and also to relieve some of the neurologic symptoms. So the Endocrine Society recommend like a single dose of 5 milligram intravenous dose of zoledronic acid as the treatment of choice in patients in which there are no contraindications. And this recommendation is generally based on 2 clinical trials where zoledronic acid infusion over 30 minutes is being compared with risedronate 30 milligrams daily. And it's been seen that after 6 months, the level of alkaline phosphatase, the onset of action, pain relief, and quality of life were more significantly better in the zoledronic acid group. So how will you assess for treatment response in these patients? If there is any urgent need to control symptoms, or if the disease is particularly active, the Endocrine Society suggests using short-term response of bone resorption markers and shortly after treatment to assess the therapeutic response. In patients also with osteolytic lesions in Pancreatic disease of the bone, so the society also recommends getting X-rays approximately every year to assess whether there has been improvement with therapy, and also to follow up with alkaline phosphatase testing every 3 to 6 months is recommended. Additional treatment can also be considered if symptoms persist or return after treatment, or if alkaline phosphatase levels rise above the normal value. So my patient, just as the recommendation by the Endocrine Society, she received like 5 milligrams of zoledronic acid infusion twice, but she has just minimal response. She's one of those patients that doesn't respond much to zoledronic acid and have this like accelerated bone growth. We also gave her like calcium, vitamin D, 2,000 units daily and 5,000 units every week. And because she has like complications, hearing loss, and visual problems, we refer her to ENT and ophthalmology. So the prognosis, this is one of the things that my patient asked me, like, how long will she live? How will this disease impact her and her life in general? Which initially I did not know the response, but most patients with Paget's disease, they live long, very healthy lives. The only thing they have to deal with is the musculoskeletal problems, which is imposed by the disease or other problems of aging. As you can see, most patients develop the disease after the age of 55. So most of them will just deal with the musculoskeletal problems and problems related to as they age. So the take-home points for this is like identifying Paget's disease of the bone in the right clinical context and knowing the differentials, just as you brought up very, very wonderful differentials. If patient present with headache and some of those lab findings and radiographic findings, you have to broaden your differentials, not to only think about Paget's, but to rule out malignancy and other diseases. So early on, you have to refer these patients to ENT, to orthopedics, depending on some of what complications that they have. And it's also important to know that serum alkaline phosphatase is a good marker for disease progression. And the treatment of choice is zoledronic acid. And it's important to know that this injection can last, a single injection can last for 3 years, especially in postmenopausal women. So it's a very, very effective treatment in patients who responds to it. Unfortunately, my patient is not responding well to zoledronic acid. And to be able to talk about prognosis with these patients and like life expectancy and some of the complications that they will have to go through throughout their disease process. Thank you. If you have any questions.
That's a fantastic talk, lady, and it is spurring a little bit of a conversation here. We do have questions related to the high PTH level, mildly elevated calcium levels or in the upper limit of normal. Some people are suggesting, and I agree, it wouldn't be justified in pedestrians, and they're wondering if this could be, a coexisting condition. If you guys ever discussed this in their endocrinic.
Yes. So very right. So a patient has elevated parathyroid and calcium is high normal values. So we are also working this patient up for primary hyperparathyroidism. It's good that you brought it up. We kind of focusing more on the Paget's disease since it's more prominent, trying to control her symptoms, get the treatment, and then we are working her up. We saw those labs also, so we are working up that as well. So she might possibly be having primary hyperparathyroidism. But just as we saw in those images and everything, primary hyperparathyroidism might not explain those sclerotic lesion and expansion of the cortex of the bone. It might not explain that. So our main problem is the Paget's disease.
This was an amazing learning opportunity, I bet. I don't know about you guys, but I never had a Paget's case, in any of my clinics, not even on endo. And there are many nuances to the treatment and even the diagnosis. Some people suggest we should get like urine hydroxyproline, and in Europe, I know that they use calcitonin, although the FDA has not approved their use for refractory Paget's. And usually what they say is that you can use pamidronate. IV bisphosphonates are, the treatment for patients who do not respond. And like Lady mentioned, and I think the presentation was amazingly summarized, where you would treat for bone pain. And there's a question in the chat that says, Nicholas, do you read about any surgical interventions in those with neurologic compromise without response to bisphosphonates? And I guess, that could be the case. I don't know about this. I don't know if Dr. Briglini knows the answer to this, but I guess if you need to treat the symptoms and it is creating some sort of, compressive disease, like you would do with other conditions, whether it's, thyroid disorders or amyloid disease. I don't know if you know anything about this, Dr. Briglini.
No, I won't be able to answer that. To me, actually, this was, I apologize because I missed the beginning and then I got distracted with phone calls.
Sorry, I didn't mean to put you on the spot.
But, the part that I caught, I thought it was a very interesting discussion because you had to entertain diagnoses that were actually quite different and not always, thought as, put together in one differential, right? Because we were thinking about polymyalgia rheumatica, the arteritis, the temporal arteritis, Paget's disease, acromegaly. I mean, it was a very wide differential that required a lot of, history and, testing. Something that, when entertaining those type of diagnoses with bone enlargement and acromegaly, sometimes it's useful to ask the patient for an old photograph to see how they compare to what you're seeing now. When you have acromegaly, what you see is that, with the growth of the facial bones, the teeth start to separate. So you should see that on the physical exam. On the picture, from their driver's license, they don't have that. The teeth are put together. So I think, that's something that is useful. To me, what's surprising about the case is that for that X-ray that you showed of the skull, I would have predicted a much higher level of alk-phos. Alk-phos, if I remember correctly, you said it was 136, right? Which is barely up. I think the maximum level is what, 125. So, that to me is a surprise because this seemed to be a very active Paget's disease, and yet the outflows was, just a tiny bit up. So I don't know if endocrine commented anything about that, but to me, it's not what I would have expected.
When I was thinking about that, the patient did have a very distant diagnosis of bone disease. I wonder if it's, the bone osteolytic or whatever, activity had already sort of remitted and she was left with the, enlargement and the symptoms from the compression itself. Yeah, I'm not sure. In any case, to me, it was clear that this patient needed treatment, particularly because of the vision and hearing loss, right? That you think it's really from growth of the bones compressing on the cranial nerves. So that's really, a must, I would say. So I'm glad that she got the treatment.
Yes. And also maybe like the reason why the alkaline phosphatase, it's not super high. Maybe he responded a little bit with the zoledronic acid that she got. So that might, kind of reduce the alkaline phosphatase level a little bit.
Yeah, very interesting. Yeah, thank you, lady.
Thank you.
Also, this patient should have echocardiogram to see a high cardiac output failure, especially when she has visible skull vessels. Might be some fistula formations into that growing bone.
That's a very good point, Wakar. Yes.
Good point. And just as I mentioned, the complications, heart failure is part of one of the complications. So yes, I agree.
Do you guys have any other questions for Lady? I'm reading here. Great job. Super good work. Everyone learned so much with this case.
Thank you. Thank you for moderating. Thank you so much, everyone.
Thank you.
Enjoy the rest of your afternoon.